Thanks, everyone. O'Neill asked me to come do this, and for those of you who know me, I know many of you in the audience, you probably aren't surprised that I told him no a few times. Noga had to twist my arm, and finally I said yes. I've always wondered why in a place where people have more letters behind their name sometimes than in their name, they want the opinion of a simple country programmer when it comes to these things, but be that as it may. We've been on a mission for a long time, over half of my life, building an integrated health system for providers, nurses, and patients. And today I want to talk a little bit about the last mile, getting all the way out to the patient. And I thought we'd start with some interesting context. We did a little study on 12 sites, average sites, nothing extraordinary, 12 average sites, to understand how many unique individuals work at those sites and touch the electronic health record of patients. So over a 7-day period, about 130,000 healthcare workers worked in the EHR, working with patients. Over 30 days, about 150,000. And then we looked at patients accessing those very same systems over that very same time frame. In a 7-day period, almost 700,000 unique patients accessed that very same system. If we looked over 30 days, upwards of 1.4 million patients accessing that very same electronic health system. What we realized, and what we've realized for some time now, is that the patient themselves is fast becoming the single biggest user, both reads and writes, of their electronic health record system. And what we used to think of as an electronic health record for the caregivers is really moving to become an electronic health record for the patients that the caregivers also use. And I wanted to give you a whirlwind tour of some of what we're building into Epic, some of what we've already built into the system. This isn't just an Epic thing, this is an everybody thing. These are the kinds of things health record systems of the future will have as native componentry. Just like when we were kids, we'd go to a car stereo store after we got our new car and get a car stereo to put in. More and more things get built in. Today's leaves become tomorrow's branches, and that's what this is all about. So here's our whirlwind tour. It starts before they're even patients, right? Making sure that you as a health system or you as a patient have access to learn about providers and pick and choose who you're going to work with. So open scheduling, a key thing in an electronic health system. And once you're a part of the health system, mobile everything, appointments, refills, all the basics, the transactional stuff. Appointment offers, I think, are cool. If a patient gets admitted for a CHF problem and they miss a cardiology appointment at 9 in the morning, what could I have done to get that cardiology appointment filled by some other patient who needed to get into cardiology? So doing things like appointment offers, as soon as something becomes available, get it out on the net, look at the 20 people on a waiting list, see who can come in tomorrow morning at 9 o'clock. Billing payments in a world of high deductible health plans, patients are going to have to pay more and more and more, and it's incumbent on everyone to streamline that process and simplify it so patients can pay when they're willing to pay. Multi-language has to be patient-friendly. And we're seeing a move from just the transactional work into the transformative work. So messaging and e-visits, photography through these devices, core part of an electronic health system. Video visits. Stanford went live on video visits into the home through MyChart a couple weeks ago. It's amazing. The boundaries are coming down. Certainly the reimbursement models need to step up to meet that need. But you can see the technology now making this simple and practical. And taking it right to the handheld, right to the iPhone, iPad, Android device. Simple things can create a lot of value. So helping a patient who's starting an electronic message to a provider with NLP, we can decide to step that up to an interactive chat based on what we see in that traffic. And if it seems significant enough, we can turn it into a phone call or a video visit or bring the patient in. So moving across a continuum that helps enable patients to get the right level of care as fast as possible in real time. Simple things like checking in, answering questionnaires as you're waiting. One of the other sessions talked about patient-entered data and being able to move that patient-entered data directly into the EHR. That, again, is something that's already been done, and people are adopting it like crazy because it saves doctors time. They don't need to transcribe information. Check-in surgery updates. How do we simplify the experience for the patient as they navigate some of the world's large and complex health systems? How do you help a new mom track information about the pregnancy? How do you make sure that that information can be used to signal the hospital when it's time to come in? The other thing that patients have a voice in is who gets to share their data. But it's an extraordinarily complicated process. We run about 1.4 million transition of care interoperable transactions per month right now. And one of the challenging pieces is how do the front desk staff manage that consent process? So moving consent out through mobility, through the portal to the patient directly so that they can manage it on your behalf is a great simplification. and as well releasing their information to outside sources. When it comes time to get the consent to release information out, you can do that as well. In the changing reimbursement model, high deductible health plans lead patients towards people who can offer transparency around pricing. And being able to get an estimate is one thing. Being able to remember that you gave the patient an estimate and honor the estimate when everything's all said and done without 5 or 6 confusing bills from different sounding places is critical as well. Patient-reported outcomes, in the spirit of PCORI, we've been doing a lot of work over the last 5 years with some very engaged sites to build patient-reported outcomes directly into the patient, the mobility, and the EHR experience. So patients can use this really in 3 different ways. If I'm a patient looking for something, looking for a treatment, I can compare and contrast alternatives, maybe surgical, maybe rehabilitation, whatever the case, medical procedures. I can compare and contrast what others have experienced who are similar to me. The second thing I can do with it is once I've made a choice, I can see how am I tracking against that choice as compared to others who made that choice. So if I've made a choice and I'm tracking below everybody else, maybe I should have made a different choice, and that might be the thing that I need to go back in and make a different choice and discuss with my provider. I'm going to move a little bit quickly here. And the patient-reported outcome information needs to be part of the chart. It needs to be available and accessible to the caregivers. It becomes part of the knowledge base that helps us research and learn and understand what treatments work, how well they work as compared to the whole comparative effectiveness aspect. So all kinds of different things that have been built in now to help bridge that gap between patient experience, patient treatment, and patient outcome, and to try to make that a holistic experience for both the patients and the doctors, and to bring that information back, that secondary use of patient-reported outcomes data, into the health system so that you can learn and understand what's happening. It's a fun area to work in the analytics space. This is one of the great repositories of information to analyze. It gives you incredible insight into how patients experience these treatments and how they experience the rehabilitation time frame and what the overall outcome looks like compared to the variety of choices that were out there. Care planning becomes another essential thing as we enter the world of ACOs. It's the ability to have micro HMOs and neural networks all across the world. Being able to be responsible for a patient's total care and be responsible for their health and be responsible for their outcomes. I think the biggest thing that needs to change is accountability for the patient. We talk a lot about accountability for the providers. I meet a lot of providers who are just sick and tired of being yelled at for things that patients do or don't do. It's fair game to ask them to do certain things, to have measures, to have quality, things like that. But at the same time, we have to find a way to engage patients at a deeper level, to make sure it's clear what they need to do, and to track and assess how they're doing against those goals. Excuse me. And this is obviously incredibly important when you're at risk financially for that patient. And that leads to health coaching. So when you look at the plethora of devices, the plethora of apps and opportunities, I see this as a situation where the apps are great, but outside the context of a health management construct, they sort of sit in silos. It's the ultimate world of silos, especially as you look at iPhones. It's amazing what Apple does to create an ecosystem, and it's amazing what Apple does to create an endless farm of silos. In the health space, having the ability to bring the patient and the patient apps, the clinicians and the knowledge of the health system and the algorithms of the health system, scrunch it all together, put it in a big blender, you whip up a pretty impressive drink. And these kind of tools help you now take what you know, what you're learning, and what the patient's learning, and continuously provide a feedback loop to the patient by way of coaching. And then to also monitor how did the patient respond to coaching, and should I take a turn left, should I take a turn right, should I stay on the course that we've got? All sorts of interesting things in that field. The other thing I want to talk about a minute is patient engagement with regard to family members. One of the cool things that we're working on, and if you work with the genomics researchers, you get a pretty clear understanding that the genomic annotation process is largely, it's an important part of that process to understand the phenotypic information about the patient. And when you talk to them, they'll tell you that a patient can report mom and dad's and siblings' health experiences at about a 50–60% accuracy. When you ask the patient about grandma and grandpa, on both sides, you're down to a 30% accuracy. The fascinating thing today, though, is that mom and dad, the siblings, grandpa, grandma all have electronic health records of some shape and size somewhere in the world. And they're going to have fairly comprehensive health records within the next 5 years. So what we're doing is creating an infrastructure for patients to allow family members to donate their actual medical history as phenotype information for the genomic annotation process. And we think that'll go a long way to simplify the genomic annotation process and also simplify how we have to collect that information. And what an impressive database of research information that's going to provide with their permissions to use it appropriately. Research is really important, and we're seeing research move out from the clinical trials and double-blinded studies out into observational research, and we think we can do a lot more through the patient engagement to engage patients in research that matters to them specifically. So we use our extensive rules engine to promote research trials that are uniquely appropriate to this patient based on their health information. And then secondly, one of the tragedies is once you get patients signed up to a research protocol, how many fall off because they're not in compliance. And in part, they fall out of compliance because they don't even know what the schedule is. So we're using these tools to help them understand what the schedule is and continuously remind them of what the upcoming steps are, what are the next big events in this protocol, so they can stay on the protocol. Taking this into the hospital, one of the new apps that we've developed is called MyChart Bedside, and what that does is it gives the patient an experience in the hospital. And all the basics, care team, education, who are these people taking care of me, what does my day look like, what does the discharge day look like, letting patients do self-assessments directly into the system, maybe pain scales, the fundamentals. These are things that almost every health system probably within the next 5 years will have found a way to accommodate in as part of their systems. Patient satisfaction helps your HCAP scores if you know who's having a bad experience this morning, and you can get in there and fix the thing before it becomes an end of an unsatisfied patient. And it's not just in the hospital, it's how do we take this information home and have a recovery companion for the patient. So that's where MyChart Bedside goes next. It goes into the home. And a lot of things you can do in the home. Continuing the educational process, you can monitor the rehabilitation process. You can have care managers interacting with the patient. The Qualcomm presentation is a great presentation, and I'm an old ham radio kid. When I was 10, I did ham radio, so I just love the radios inside these phones. I'm still fascinated by that. I used to build them when I was a kid. And what's impressive is I've got the form factor, the usability, and the communications all smashed together in these little devices. And I can do things like this without crawling under Grandma's desk looking for where the internet jack might be. And I don't have to do the kind of tech support at Grandma's house that one would otherwise have to do. And these devices are getting so inexpensive that for $100, $150, $200, I could hand it to the patient with maybe a 45-day 4G LTE connection, and they could take it home, and I could teleconference with them twice a day. I could get medication administration record. I could have them take pictures of the wound, show me how it's recovering, things like that. So this, I think, is going to be one of the more important things for the future. The other thing that is just amazing these days is this, the consumer devices and how they connect in. This device that you send home with Grandma can actually be the hub to collect all the biomonitoring data and stream that back to the clinicians. And obviously, you're not just streaming it to a clinician's in-basket or flow sheet or something. What you're really streaming it to is a set of pretty sophisticated algorithms in the computer that are watching for trends and patterns. They're watching for situations that don't look good so that you can take your critical resources and deploy them where they're needed, and you can identify who's actually doing well and probably could do a once-a-day check-in versus those who are struggling and need a 3-a-day check-in. And in theory, this was possible. I don't know. We did this back in the early 2000s. But the puzzle was, it was just really expensive, it's kind of clunky, and it just had a lot of infrastructure needs. And although you could, in isolation, prove a value, prove a use case that would make a difference, in practice, nobody really did it. What's fascinating now is the Wi-Fi, the Fitbits, these things are consumer grade. They're very, very economical. They're very, very standardized. And it's providing us with a new opportunity to do things opportunistically that we really couldn't cost justify before. And that market is just totally exploding. It was fun to walk through the exhibit hall. You saw some of these kind of things in there. And we're just at the start of it. What I find interesting about healthcare is that so many people hop up on a stage and talk about their new thing, and the first thing you hear is 5 minutes of disparaging healthcare and disparaging the past. I've always felt that that's inappropriate, because what's truly amazing is to think about healthcare today and where we were 20 years ago, 50 years ago, 100 years ago. What people in healthcare do is extraordinary, and it's amazing. And what's truly amazing about the last 100 years in healthcare is to realize that if you connect the dots, it draws a line. And if you follow that line out, it tells you where we're going to be in the next 5 years, 20 years, 50 years in healthcare. And that's the exciting part. That's the draw, I think, that gives me and our staff the happiness of working in healthcare. And it is truly amazing. And one of the things that we all recognize, no matter what it is you do, no matter how good you are at doing it, there's always a periphery. There's always something on the edge. Like I mentioned, what we do is the tree and the leaves are the edge, and tomorrow the leaves become branches, but there'll still be new leaves. So one of the things that we're really focused on is how to make sure that the systems are open in such a way that you can pull information in and share information out with things that are at that periphery. It doesn't excuse us from the heavy lifting of doing what needs to be integrated. At the end of the day, we have to do what needs to be integrated, just like your car. When we were kids, you could go get a car stereo and put it in your car. Today, if you bought a new car, can anyone imagine replacing the car stereo in your new car? It just doesn't make any sense. Kids look at me like I'm an idiot. Like, how would you get that out of there, Dad? So no matter where you are, how good you are, there's always a periphery. And one of the things we're focused on is trying to find ways that we can appropriately testing, verification, try to make sure that we open up that periphery in a medically safe way that doesn't create chaos and disorganization inside the health system, who is liable to take good care of that patient, who does have to organize the chaos, who does have to organize the care. So we've opened up a plethora of websites, in particular around some of these consumer diagnostics and consumer monitoring devices. And as well, we've published out all the different integrations we've done through time. Today, we process about 20 billion transactions per year with modular third-party systems. And that's growing. And mostly through web services, some traditional interfaces. But for all the people who are coming up with a new and clever idea, these are the methods that people will use to connect that idea with a health system, like a Partners or a Kaiser or a Leahy or a whomever. And it's really going fast, and it's fun to watch. What that allows us to do is to take this new world of apps, this new world of devices, this new world of opportunity, and integrate it into the patient experience, create some order to the chaos in a way that health systems and people who, no matter how many apps you have, you won't do away with your doctor. You'll always want a doctor, a trusted advisor, someone who helps bring this all together for you. And your doctor and your health system will be the people that help you organize a world of apps. We'll see prescribing of apps. You can already see that in some markets. So patient engagement tools like a patient portal, like the mobility aspect of it, will help you organize those apps, register them appropriately and securely, and make sure that the doctors understand what might be coming in, how they're going to do it. The health systems can tune up their algorithms to make sure they can use that information properly. And that opens up a whole other world of visualizations, a whole other world of understanding patients. And again, it's fun to be a vendor in this space, but for 26 years, I've realized there's always that periphery, and there's always a great opportunity for people to do clever and creative things on that periphery. So we're very excited about this. And those apps can be independent and talk into the core system. They can also be part of an app library that can participate in some of the engagement tools more directly. And in my last couple of seconds, the only final question left in this last mile is, what will your mile time be? This is moving fast, and if you look at the last 10 years, these kinds of things are critical right now. And the movement in this direction is so fast and so swift, it's one of the biggest changes I've seen in healthcare. So with that, I will leave you. Thanks.